one case already.
Ah.
Huge, sir. Submandibular, sir. 850 grams, sir. I told Kanak will give me next week.
Sir, you are there, sir, for next week. No problem.
No, sir, we have to put the tundu boat seat powder. We have to put down. So many people are approaching.
So I think we have Professor Shamita Chatterjee. We have Professor Shantini ma'am. We have Professor Kiledar ma'am joining us. So we have our regular faculty, Professor Rajgopal sir, Professor Ajit Sahay sir, Srinivasan sir, Karnakaran sir, and many more faculty who are with us. So we have Professor Kiledar ma'am joining us. 1 second. So we have Dr. Shamita ma'am. We have Dr. Madhura Kiledar, and we have our new invited faculty, Dr. Rajgopal sir's guest, Dr. Ravi Goda from Professor and HOD from Hassan. And we have other senior faculty who are with us. Professor Shantini is from Trichy KAPV Medical College. Welcome, Shantini ma'am. So we have two important cases for the day. I also warmly welcome the PGs and the faculty who are watching in the YouTube channel. So this is a very important session as we had the International Women's Day. Today all the faculty, invited faculty are women faculty. So thank you for joining us, madams, from across the country. And we have two postgraduates. One is Dr. Swarna Varsha from my own institution, Dr. St. Isabel's Hospital. And we have Dr. Arjun, kindly contributed by Karnakaran sir, and he is from the Madurai Medical College. So he is going to give a talk, give a presentation on breast cancer. So with that information, now I would call upon Dr. Arjun to kindly share. I would request the invited faculty to take charge of the presentation and moderation. Of course, other senior faculty will definitely chip in. They need to add up some information or give their comments. So the priority will go to Professor Shamita ma'am, Professor Madhura Kiledar ma'am, and Professor Shantini ma'am. I expect Dr. Madhura, Dr. Gore ma'am, Madhuri Gore to shortly join us. And we have our senior faculty also be chipping in for that thing. So the priority is for the invited faculty. So I would now request Dr. Arjun to introduce himself, his unit chief, his HOD, and then start his presentation. Dr. Arjun, good luck to you.
Yes, sir. Good evening, sir. Good evening to all the respected faculty and professors. Myself, Dr. Arjun Raj, General Surgery resident from Madurai Medical College. I'd like to thank Professor Dr. A.M. Syed Ibrahim sir, my HOD, for giving me this opportunity, and my unit chief, Dr. V. Selvaraj, and my guide, Dr. K. Karnakaran sir, for giving me this opportunity to present. Shall I start, sir? Am I audible, sir?
Yeah, you're good to go, Dr. Arjun. Please start.
Yes, sir. Mrs. X, 60-year female from Madurai, presented to our OPD with a chief complaints of lump in the left breast for the past 2 years. The patient was apparently normal 2 years back. Then she noticed a painless progressive swelling in her left breast, which was approximately 1 centimeter and
You've muted yourself, Arjun.
Am I audible now, sir?
Yes, you're audible now.
Yes, sir. There is a history of nipple retraction present, but this nipple retraction is not of recent onset. And discharge, no history of any other swelling in the opposite breast or both the axillas. There is no history of swelling noticed over both arms. There is no history of breathlessness or cough, abdomen distension, jaundice or abdomen pain, or headache or seizures. There is no recent onset of back pain or bone pain. There is no loss of weight and appetite. Patient is not a known diabetic, hypertensive or asthmatic. Coming to past history, there is no history of tuberculosis or contact with tuberculosis patient. There is no history of ischemic heart disease. History of peripheral sterilization done 32 years back. No history of hormone replacement therapy. No history of any drug allergy. No history of any irradiation in the past, and no history of any previous breast surgeries. Coming to personal history, patient takes mixed diet, not a smoker, not an alcoholic, normal bowel and bladder habits. The menstrual history, patient attained menarche at 17 years of age, attained menopause at 50 years of age, which is 10 years back. The cycles were regular previously with 4 days bleeding. Coming to the obstetric history, patient married at the age of 18 years, childbirth was at 19 years, a P4, L4 and no history of abortions. She has 3 daughters and 1 son, and all of them were breastfed for 6 months. And coming to family history, there is no history of breast, colon, pancreatic, ovarian malignancy among family members in both maternal and paternal side for 2 generations. And coming to the treatment history, on August 2020, patient was evaluated in a nearby hospital. The biopsy taken from the lump and it was proven to be malignant. And patient has undergone 8 cycles of chemotherapy in our institution. And the biopsy and other details and imaging are not available with the patient now. And I'd like to give the summary. 60-year postmenopausal lady with painless progressive lump in the left breast for the past 2 years with no nipple discharge and who has completed a neoadjuvant chemotherapy.
Arjun, this is Dr. Sahai. Arjun, you said that there is no history of recent, or there's nipple retraction, but that's not recent.
Yes, sir.
So what do you, why, how long was that nipple retraction there for?
The patient gives a history of nipple retraction present for approximately 40 years, sir. Patient was able to breastfeed all the 4 children with the nipple retractions.
With the same breast? With the same breast?
Sir?
With the same breast?
Yes, the nipple retraction was present in both the breasts, sir.
Yet she could breastfeed the child?
Yes, sir. She said by stimulation, she was able to feed. There was no feeding difficulties.
Arjun, go back to your first
Do you know
slide.
there's a theory called Workhouse theory of chronic irritation? Have you heard of this theory?
I've not heard, sir.
Workhouse theory of chronic irritation for breast cancer.
I'm not aware, sir.
Okay. So nipple retraction for a long time can lead to stasis in the duct, leading to irritation and breast cancer.
Okay, sir.
How much is the patient educated? Is the patient educated or not educated?
Patient is not educated, sir.
Right.
She belongs to lower.
In malignancies, it's important to tell us the level of education, because why?
The follow-up.
So that they understand what is happening, because the treatment will be long drawn, and then the follow-up also will be long drawn. So they should understand, right? That's why it's important.
Yes, sir.
Arjun, Dr. Shamita here.
Yes,
Taking off from what Dr. Rajiv just said, you were a little happy with the fact that it's the duration of the retraction has been for a very long time. So what was the reason for this taking it lightly? I think he brought you back saying that a chronic retraction can be a cause of malignant change. But if we usually get a history of a prolonged retraction over a period, what could be the other causes of retraction? Is it only malignancy, or what could it be?
Could be due to other congenital reason, ma'am. Could be due to congenital retraction.
Congenital. It could be of long standing, as you said. You said 40 years. Could there be any other reason for the nipple retraction? Could there be any benign reasons for a long standing nipple retraction? You can have ductal ectasias, which might lead to fibrosis and retraction also. So normally long-standing nipple retractions are indicators of benign disease, but as Dr. Sahai said, they can also progress to malignancy. So don't get relaxed the moment you hear that he's been or she's been having it for the last 20 years or 40 years, as you said. There was one more point you said, that there was no discharge. Now, in this lady, there was no discharge, but if the patient did complain of a discharge, what are the other histories that you would like to take? Any other detailing you would like to know regarding the discharge?
Yes, ma'am. I would like to know whether it's unilateral or bilateral, whether it was spontaneous, and I would like to know about the quantity and the color of the discharge, whether it was serous or serosanguinous or sanguinous, so bloody.
So which are the ones which raise an alarm bell? Which are the discharges which will immediately make you alert that there's something not right?
If it is unilateral, if it's spontaneous, and if it's serosanguinous, it's
Not
more in
serous,
favor of malignancy.
more of serous. Serous is serious, that's what they say. So yes, if it is unilateral, if it is spontaneous, if it is serous, yes, bloody discharge does tell you that there's probably an intraductal neoplasm, but that which could be either a papilloma or a carcinoma. But yes,
Yes, yes, ma'am.
okay.
I think probably the most important history in the discharge from the nipple is whether it is occurring only from one duct or multiple ducts.
Single
That's
duct.
probably single duct discharge is probably the most important one.
Yes.
So you should always mention about that.
So single, spontaneous, serous. These are the three S's that you have to be alert about when you are taking a history of discharge. Okay, could you move to your next slide, please?
Arjun, in this slide, when you write the Mr. or Mrs. X, that is not good. Okay, we have to give the respect to our patient. You can simply say it's a 60-year post-menopausal lady, rather than saying Mr. or Mrs. X or like that. That doesn't look nice. Okay.
Okay,
Yeah.
Arjun, I just want to ask you one thing.
yes, sir.
Now that you said that she's had a long-standing nipple discharge, nipple retraction, this can lead to ductal ectasias, can't it? Irritation and ductal ectasia. So there is an entity which mimics malignancy very, it's a benign condition, but mimics, it's very difficult to distinguish between malignancy and that condition. Do you know what condition is that?
It's a radial scar.
Radial scars, very good. Radial scars are one thing which is very difficult to distinguish even by radiological or by clinical means, even by histopathological means from malignancy. Very good.
Adura ma'am, you wanted to add something? I saw your finger going up. Yes, madam.
Yeah, you in the presenting illness, you have written here that she was apparently all right 2 years back and she noticed lump, but after that she has taken chemotherapy.
Yes.
Is it? She has taken chemotherapy from some outside hospital or from in your hospital?
She has taken chemotherapy from our hospital, ma'am. From after August, by September, she has started, ma'am.
Okay. Then when you give chemotherapy, when you have given or your department, some unit must have given that. So in that details of the histopathology report must be available, no?
Yes, ma'am. Yes, ma'am. I have to go and collect
so
it, ma'am.
You have written details. Yeah, because now you have to plan for this patient for surgery.
What?
Can you hear me?
Yes, ma'am. Yes, ma'am. I have to go collect it, ma'am, from the Department of Medical Oncology.
I think what he said was that the patient present does not have details of therapy that she has received. Right, Arjun? Is that what you said?
I'm sorry, ma'am.
Presented was
What
chemotherapy.
What
but
I think in the history of present illness only.
Not able to hear you, ma'am. Voice is breaking, ma'am.
Arjun,
Yes, sir.
Dr. Rajgopal Shunai here. Just
Good
want
evening,
to
sir.
ask you one or two things. Since the issue of radial scar came, you should understand that don't try to say it clinical aspect about that. Okay. Only let the examiner ask you pathologically, please answer that. Otherwise, we don't make that discussion in the clinic in the sense whether the patient has radial scar. One. Second thing is, what are the other conditions? What are the other conditions which can mimic carcinoma of the breast? I am talking from the clinical angle, not from the microscopic angle. Not from the microscopy. She is of course 60 now. Otherwise, one or two other conditions.
Not in this patient. Granulomatous mastitis can present.
So,
Patient is diabetic. If the patient is diabetic, I would suspect.
Don't bring diabetes into discussion.
Okay.
What you told me, right? There is lot of disturbance. Please switch off the mute the mobile phones, please. Lot of disturbance is there. So if a patient is 35 to 40, sometimes they do complain of, so if there is a pain, if there's a woody induration and with or without discharging sinuses, it can well be a granulomatous mastitis and even tuberculosis also. So you need to, if the patient were to be younger. So with this patient does not have pain, progressive lump, so for which you mentioned that it has increased to whatever current size, and for which she received neoadjuvant chemotherapy. That's what you are telling, correct?
Yes, sir.
Yeah.
Yes, sir.
What are the other history which you have to ask, which you are not mentioned here? Straight away you went there.
History of.
Sorry to break you, sir. We have Professor Madhuri Kure ma'am joining us from Mumbai. She was the former professor at the LTM Medical College Hospital. Welcome, madam. Madhuri ma'am.
Sir, I would.
Madhuri ma'am. Okay, please go ahead, Arjun. Sorry.
Sir, good evening.
Good evening, sir.
Apart from the nipple retraction which you are given here, so there's a progressive painless lump, number one. Number two, nipple retraction, which has been clarified now by many. Anything else which is important, which you have to mention?
Sir, I would like to ask history of trauma, sir, and history of fever.
Why fever?
Fever can mastitis.
Do you expect 60-year lady to get mastitis?
No, sir, not in this patient.
What are the common causes of mastitis in a woman, or even for that matter, males also can get? What are the types?
I'm sorry, sir.
What are the types of mastitis?
Mastitis, the costochondritis teeth syndrome.
No.
Mastitis. Don't mix up things. Mastitis.
I didn't ask you differential diagnosis of mastalgia. I asked you what are the causes of mastitis. See, you can, that's why don't unnecessarily get into trouble. Fever you mentioned, so we ask you lactational and non-lactational puberty mastitis. So there are various causes are there. Just go through about it. So in this 60-year lady, you don't consider that. You understand? Not that common.
Yes,
so you mentioned about nipple retraction. You mentioned about other things. No. So the next slide is Madam Shamita Chatterjee. Please take over, Madam.
Yeah. About mastitis and trauma, both things. See, she has a history of 2 years. So if it was either trauma or mastitis, both would be a short duration history. So whenever you have such a prolonged history, obviously we are not looking at a traumatic or an inflammatory pathology. Okay. So we'll move on to the next. You said somewhere that she underwent a biopsy. What sort of biopsy do you think she underwent? Do you have the details for that?
I don't have the details, ma'am, but she underwent a core needle biopsy, ma'am.
She underwent a core needle biopsy. That we are satisfied with. Okay. So she underwent a core needle biopsy, and following which she has received 8 cycles of chemotherapy. That's what you said. Has there been any change in the status of the lump Has she given you a history that with the chemotherapy, whether there has been any change in the status of the lump?
Yes, ma'am. She has said that size has reduced from what it was previously, ma'am. And she,
Other than the swelling in the breast, did she complain of swelling anywhere else? Did you ask for her in the history? I know you've not examined her yet, but did you ask for any history, whether she had any? If you were to,
yes,
would you
ma'am.
ask?
Yes, ma'am. I asked, ma'am. She said no other swelling was present, ma'am. She was not aware.
When she asked for any other swellings, what all were you expecting?
I asked whether there was any other swelling in the axilla or the swelling of the arm to look for whether the axillary nodes were involved. And I also asked if there was any swelling in the neck, ma'am.
So you have to ask for the swelling in the axilla, swelling in the arm, swelling in the supraclavicular or neck region, but please also find out whether she has any other swelling in the opposite breast as well. So don't get carried away with only the main clinical feature. Now, could we come to your examination findings, please?
Yes, ma'am.
Arjun, you asked about the previous breast surgery.
Yes, there was
What was in your mind?
Yeah. And
So
what I want to say something.
Patient undergone any surgery or excision biopsies or any previous benign disease could be as a risk factor for I wanted to rule out the risk factor for carcinoma, sir.
So which benign disease you are interested?
So atypical ductal hyperplasia, sclerosing adenosis, and
would adenosis be a risk factor? You said you wanted to rule out risk factors. Would adenosis be a risk factor for malignancy?
No.
So which risk factor?
Atypical ductal.
Atypical ductal
hyperplasia, yes.
Lobular carcinoma in situ, atypical ductal hyperplasia, proliferative, diseases, rather than sclerosing adenosis and radial scars are, they're not proved to have any pre-malignant. You probably can also mention duct papilloma, I suppose. Yes.
Okay. What specifically you ask about the family history? Like if somebody has a cancer in the family.
I think he covered that. Could you go to that slide, please? Your family history slide. I think he gave quite an elaborate family.
No, but what he has to ask about that, yeah. There is no family history, but if there is a family history there, what he's going to ask? Like mother had the breast cancer, what are you going to ask?
Would you like to know?
First, I would like to ask at what age was she diagnosed? I would like to also ask whether she had unilateral or bilateral.
Good, yeah.
It was associated with any other tumor like ovarian neoplasm.
Sure.
Then I would like to see whether it was premenopausal or postmenopausal.
Yeah, that's fine. Yeah, absolutely fine. Yeah. Okay, go ahead.
Yes, ma'am.
In the history of present illness only, I think you should have included the history of chemotherapy because it is the continuation of the same illness which she is having.
Yes, okay, ma'am.
Because it should have started with the patient has taken chemotherapy about 6 to 8 months back, and whether she lost follow-up and all that, and now she came for this illness like that. You should have continued instead of tailing into I think you have told in a drug history.
Yes, ma'am.
If others agree, shall we move
on? And here in the summary itself, you should have
Arjun?
You are not
yes, sir.
I don't know. Madam, you are
not audible, madam.
Sorry, ma'am's net is not okay, I think.
Arjun, can you go back one slide? Just one slide, go back.
Yes, sir.
Go back, sorry. Go back. Yeah, just hold on. Yeah. So, see, I know what you are trying to tell, but remember, you don't have to go up to the level of seizures See, see, it's not required unless if a patient tells you, you tell. So tomorrow, everybody with the seizures means differential diagnosis, they will tell carcinoma of the breast. You need to understand what we are talking. You are talking about abdominal distension, jaundice, abdominal pain. See, there is a limit for mentioning the metastatic workup. So most common things you mentioned, and that should have taken the first priority. You know, that is backache. You understand? So
Yes, sir.
priority should have been two things. Two B's, we call it a backache and breathlessness. Backache is for the spine, more common. Paravertebral veins. So you should know about that. And breathlessness, again, pleural effusion. Effusion is more common than pulmonary secondaries. After that, abdominal pain, distension, all those things will come. So don't, I think this is my personal opinion and many places, you don't have to go up to the level of convulsions and all that thing. Okay. So it is understood.
Okay, sir.
Okay. Yeah. That's
The
all.
thing I'd like to add on this slide is that breast malignancy is one where we do not really get patients with loss of weight and appetite. This is a common manifestation of other malignancies, but in breast malignancy, this is not a very common finding. So loss of weight and appetite will not be very significant in this case.
Okay. Shall
Can
I go
I
on with the
proceed to
exam?
the clinical examination?
Yes,
please.
ma'am.
Yeah, Arjun.
On general examination, patient was moderately built, moderately nourished, conscious oriented, afebrile, ECOG of 0. Patient has a loss of scalp hair and blackish pigmentation of all the nails of both upper limbs and lower limbs. No upper limb edema. And there is no pallor, icterus, generalized lymphadenopathy or pedal edema. The vitals, temperature was normal, pulse rate was normal, 90 per minute, normal rate, rhythm, volume, character. BP was 120, 80 mmHg. The respiratory rate was 12 per minute. Coming to local regional examination, examination of the breast and axilla, the patient was informed, and after obtaining informed consent and female attender by my side, I examined the patient and exposed from neck to the abdomen, and examination was done with adequate light. Now on inspection was done in sitting position, arms raised over the head, arms over the hip, and on leaning forward. And the right breast and the axilla appears to be normal except for the nipple retraction. The left breast looks slightly enlarged. This is the clinical picture. And coming to the inspection, and left breast fullness is seen in the left upper outer quadrant from 1 o'clock to 3 o'clock, of size approximately 3 cross 3 centimeters. And the skin over the lump shows no dilated veins, ulcers. Biopsy scars are seen, and the left nipple is retracted. The left areola appears normal. Arms and thorax shows no dilated veins, nodules, or edema. Left axilla appears normal, no supraclavicular fullness on the left side. And on raising the arms above the head, nipples were retracted on both sides. Skin over the lump appears normal. Inframammary fold appears free. Then it's normal. Then with the arms over the hip, the left breast fullness becomes more prominent. On leaning forward, both the breasts forward equally.
See, when you are asking the lady to lift her arms, what are the things that you want to look out for?
And then palpation I did in supine.
Arjun, can you hear me?
Arjun, don't keep these photos for a longer period. Please take it out immediately. That could be a problem of the tubes. So
I think connection is lost.
but, recently in the ASI, one of the programs, they actually completely canceled the program because some private parts were shown. So I think Arjun.
The left breast, there's no localized temperature.
Only block the Facebook account of
Sorry,
ASI.
ma'am. Am I audible, ma'am?
Arjun, are you back with us?
Yes, ma'am. Am I audible now, ma'am?
Okay.
Yes.
Okay, as sir said, just remove the clinical image for the time being. What I wanted to know is that you said that you examined with the arms raised above the head. So why did you do that? What information were you seeking when you did this?
Arjun, you can switch off your video. I think his problem is that. See, again, he's.
The connection is lost.
Arjun, switch off your video, and then I think it'll be okay, I suppose. So basically, this whenever this the benefit for all the postgraduates who are listening.
That issue in my laptop. I'll just speak. Just a minute.
Postgraduates who is presenting the cases, especially the breast and the genitalia, etc. So they should be not be keep for a longer period and should be as far as possible try to avoid while presentation. Okay, Arjun, you are there.
Just a minute, sir. 1 minute, sir. I'm just logging in for my laptop, sir.
Madhuri ma'am would like to give you her comments, madam. Sorry, we could not have you on board on time. Sorry about it. Madam, you are in mute mode, I guess, madam. We are not able to hear you, ma'am. Arjun, you are with us, Arjun. Back to us, Arjun. Dr. Arjun.
Kanakvelu.
Yes, sir. Yes, sir.
He told me he's trying to log on through the laptop.
Yes, sir. Yes, sir. Yes, sir. He has joined in, sir. Just now I allowed him in the waiting room, sir. That is why, sir.
Sir, am I audible, sir?
Sir, you are good to go, ma. Please continue. You are able to see your PowerPoint also.
Yes, sir. The palpation. Coming to the palpation in supine position and recumbent position, it was done. Right breast and axilla is normal. Left breast, there is no local rise of temperature. It is not tender. And on examination, 2 lumps are palpable in the breast. A lump is palpable in the left upper outer quadrant, extending from 1 o'clock to 3 o'clock, measuring 3 cross 3 centimeter in size, ill-defined, irregular margins, irregular surface, and hard in consistency. And another lump is palpable in the retroareolar region from 12 o'clock to 2 o'clock position, measuring 2 cross 2 centimeter in size, ill-defined, irregular margins, irregular surface, and hard in consistency. The skin over the swelling is normal. The lump are mobile along with the breast. Intrinsic mobility is present. It is not fixed to pectoralis major and it's not fixed to the chest wall. And left axilla, there is no palpable lymph nodes. In the left supraclavicular region, there is no palpable lymph nodes. In the PV and the digital rectum examination was not significant. There was no mass palpable. And other systems like cardiovascular system, respiratory system, and CNS were normal. And abdomen was soft. And spine and cranium was normal. The summary is a 60-year postmenopausal.
Arjun, please wait. Madam wants to ask something. Shamita ma'am, over to you.
Just want to put in a few questions here. Right at the beginning, when you were inspecting the patient, you said that you would like to inspect her with her arms raised above the head. So when you do that, what are the things that you look for? Clinically, when you raise her arms above her head, what are the things that you look for?
Sir, ma'am, I would like to look for the inframammary region, inframammary fold. Then I would like to look for any swelling in the axilla. I would like to see whether the nipple was any nipple retraction is present, and if
Is already
any PUD
in
PUD
her
orange.
right, PUD. So when you raise your hands above the head, you're looking at the not only the inframammary crease, the lower part of the breast, which may otherwise be not visible when the patient is sitting straight, right? So you would like to appreciate whether there's any PUD orange. Also, the lump that you're talking about, that gets much prominent when you raise the hand. Okay, so that might become more prominent. A small lump which may not be obviously visible may become quite prominent when you raise the lumps. Secondly, when you were palpating her, you said you made her lie down in a supine position. Now, if you make the patient lie down totally supine, what is the problem that you might face in palpating her?
Ma'am, supine position is ideal for palpating the inner quadrants, ma'am. For the because when the patient is lying supine, the breast tissue will fall outwards, so that I will be able to palpate the inner side. For palpating the outer quadrant, I would like to put the patient in the opposite recumbent position, ma'am.
Right. So you've answered your own query that in the supine position, yes, the inner quadrant is better palpable, but particularly in a 60-year-old lady, what you can expect is the breast to fall sidewards. At the same time, if you make her sit up, the breast may fall more to a sag towards the abdomen. So rather than a totally supine, a more suitable position for examination will be a semi-reclined position, maybe around 45 degree, with the affected side arms above the head. So this will give you the ideal position. So not a full supine, semi-reclined at about 45 degrees with the arm of the same side above the head. That gives you the most optimum position for examining the patient. Okay?
Yes, ma'am. Yes, ma'am.
You've said that there were 2 lumps. I think I missed. Did you have any comment on the nipple? Did you mention anything about the nipple areolar complex other than the retraction?
No, ma'am. The nipple area complex is normal, ma'am. There is no discharge even on palpating, and the areola is normal, ma'am.
Okay. So there are 2 lumps, and in the axilla you did not get any other swelling. Your supraclavicular region is within normal limits, and there was no arm edema, right? Is that what you said?
Yes, ma'am. Yes, ma'am.
Can I ask a question? Arjun?
Yes, sir. Yes, sir.
You said 2 lumps, no?
Right.
Yes.
So
Yes.
do you think the second one, what you felt, is a satellite nodule, or do you think it is, what is that?
Sir, I think it is another primary. It's a multicentric because there is more than 2 centimeters of normal tissue between the 2 lumps.
And anything else you want to say? That satellite nodule, when you say, so it is intraparenchymal, inside the breast, no? Correct?
Yes, sir.
What you are telling
Yes,
is
sir.
intra. So that is the important point here to mention. Okay. So it is within. So obviously multifocal or multicentric, whatever way you want to call it as. So 2 centimeters of the tissue is also remaining. Adding on to what madam said just now, supine position is the best for what examination in carcinoma of the breast. Can you tell me? It is not for the breast. It is for the abdominal examination. Abdominal examination for the metastasis to detect. And I have seen your presentation at the end. You have started PV, PR and all that thing, and much below abdomen comes. Last your slide I have seen. Anyway, you need to change your slide. Okay. Change the method of examination. Yeah, that's all.
So in summary?
A 60-year postmenopausal lady with complaints of lumps in the left breast for the past 2 years in the left upper outer quadrant and retroareolar region, who has completed neoadjuvant chemotherapy. It's a case of carcinoma of the left breast post neoadjuvant chemotherapy.
Page YCT2 and 0. Anything else you would like to add to the diagnosis? Carcinoma left breast post NSCT. Anything else?
With no evidence of metastasis.
Carcinoma of the left breast breast in a post-menopausal patient who's received post-neoadjuvant chemotherapy with clinically no evidence of distant metastasis. Right. So these are the things we would like to know. Her menopausal status, because that is also going to, your adjuvant therapy is going to depend on that, and whether clinically she has any evidence of distant metastasis. So
how did you say that it is not fixed to the chest wall?
Pardon?
How did you say it is not fixed to the chest wall?
Sir, by palpation, sir, I asked the patient to keep hands on her waist, on her hips. Then I looked for the mobility. The swelling was mobile on both perpendicular and it was horizontal and vertical. It was mobile, sir.
Do you understand what is chest wall?
Chest wall.
Yes, sir.
Do you understand that? What is chest wall in relation to the cancer breast?
Chest wall includes the intercostal muscle, serratus anterior, and ribs, sir.
So if there is a lump which is fixed to the ribs, cartilage, and the intercostal muscles, do you think that will be mobile?
No, sir. It will not be mobile, sir.
So the lump will not be mobile. But which lump can be mobile, though it is still fixed to the chest wall?
Okay.
If it is involving outer lower quadrant, sir.
So to which area it is fixed?
Serratus anterior.
Yeah. So for that you have to demonstrate. Okay. Otherwise, this lump will be not mobile to say it is fixed to the chest wall. But if it is to the serratus anterior, then you have to demonstrate that.
Arjun.
Yes, sir.
Somewhere I think I saw you mentioned patient's hands on the hips, contraction, breast becomes more prominent, correct?
Yes, sir. The swelling becomes more prominent, sir.
Is it important here? Do you have any doubt about the existence of the breast being deeper to the pectorals or superficial? What is the whole purpose of doing the test?
No, sir, that is just to look for the mobility, sir. That is just an additional finding, sir.
See, Arjun, don't commit such blunders in the examination. Okay, breast is subcutaneous structure, correct? You have any doubt?
Yes, sir.
You have any doubt?
No, sir.
So then,
no, sir.
Is pectoral contraction is required to know that it is a breast swelling? No. So what is the idea of doing that pectoralis major contraction test?
To look for the fixity to the pectoralis major, sir.
Say that, okay, right? So we know that breast is a subcutaneous structure. The purpose was earlier Manchester staging had that component, pectoral major fixation or no fixation, okay, right? So just to be very clear on that issue, I said this, okay, all right?
Yes,
one more question from my side, because you have written your stage. What do you think the original stage of this patient? Very important. What do you think? At least,
sir.
Tell.
With the history given by the patient, I think it will be T3, sir. I am not able to assess the nodal status, sir.
Okay. Okay. My question to I'll make myself very clear. She had a T3 lump with a supraclavicular node. What is the original stage it becomes? Just to ask you this question. And today now there is no supraclavicular node. Does the stage changes?
No, sir. Supraclavicular is not considered as metastatic.
No, not that way. What I didn't mean that way. What I am trying to tell is, after neoadjuvant chemotherapy, let us say the whole lump may disappear, whole lump may come back to 1 centimeter. That will not alter the original stage. You should remember that point. It will remain the same original stage for the treatment. Okay, right, madam. Please take over.
I think when Dr. Ajay was asking you about fixity to pectoral chest wall, there are two very clear things that you have to say. That how do you know whether there's fixity? Number one, on inspection, you had said that you ask the patient to lean forward. Now, if both the breasts fall forward at the same level, obviously it may tell you that probably there is no fixity, probably. Secondly, when you are examining with the hands of the hips, the first step is when she holds the hands of the hips, you ensure that the pectoralis muscle is relaxed, and then you look for the mobility. Then you make the muscle contract and check for the mobility again. So in the first step, with the muscle relaxed, when you're checking for mobility, if the mobility is restricted, you will immediately suspect that probably there is infiltration into chest wall. Okay, so two things which will tell you that, one an inspectory finding, the other a palpatory finding, which might tell you whether the mass is fixed to the chest wall or not. Secondly, regarding fixity to the pectoralis major, remember it doesn't change the staging of your disease, fixity or not fixity. But fixity to chest wall definitely changes the disease. So you have to be very clear about your clinical findings when you say this, right?
Yes, ma'am. Yes, ma'am.
So with this staging, what do you say? Would you call it an early breast cancer, or would you call it a locally advanced breast cancer? Would you call it a metastatic breast cancer? What would you like to call your patient?
With this stage, I would like to call it as early breast cancer, ma'am. But the staging usually first, what at presentation, what was the at presentation we have to see the stage, ma'am.
Exactly what
staging will not
just now, that the post neoadjuvant will not dictate the staging. The staging is what the patient primarily presented to you with. So if it was, as sir said, if it was a T3 with a supraclav and an M0, what would you think? What would you call your patient? Would you still call it an early breast cancer, or would you call it something more?
I would call it locally advanced breast cancer.
By definition, what is a locally advanced breast cancer? Which patients would you call? What do you understand by the word locally advanced breast cancer?
Any patient with no T3, T4, no, N1 stage and N2 stage.
T3, T4, N1 stage. T3 with N1, N2 or N3. T4 with any N. Okay, so all these are stage 3 disease, or any T with N2 and N3. All of them will come under the LABC. So by principle, it will be an advanced breast disease which has progressed locally. That means from the breast and the axilla, but does not have any distant metastasis. That is what is a locally advanced breast cancer. Fair enough. So how will you proceed with this patient? What would you like to do now?
Madam, one moment, madam. Yes. I think Professor Madhuri wanted to ask something. Am I right, ma'am? I saw your fingers go up, madam. Please. Madam, we are unable to hear you, ma'am. Madam. Madhuri, ma'am, I will request you to log out and log in, ma'am, because try now, ma'am. Ma'am, we are unable to hear you, ma'am. I request you to log out and log in, ma'am, if it is fine. Yes, madam. Shamita, ma'am, please take over.
Should I?
Yeah. Yes, madam. Yes, madam.
So I'll go back to what I was asking you, that let's assume that this is not a post-NACT patient. Let's assume that the patient has come to you up front. How would you like to proceed with this patient?
I would like to first confirm the diagnosis, and I would like to stage the disease, and I would like to do basic investigation to find out for the treatment for the patient. I would go ahead with the general condition and the status of the patient, and I would go ahead with triple assessment, ma'am.
Right. I think as an MS or a DNB candidate, that's the first thing we want to hear from you, that I would like to complete my triple assessment, which will help me confirm my diagnosis, stage the disease, plan my treatment, and do the necessary other investigations to fulfill my treatment plan. So how would you like to confirm your diagnosis?
I would like to confirm my diagnosis by core needle biopsy, ma'am. Probably ultrasound guided.
You want this lady, you want an ultrasound guided core needle? Can you not?
No, not for this. if preferable, ma'am, if ultrasound guided is present, I would like to go ahead with ultrasound. If not, just blind, I would like to take the biopsies.
It's a large mass, you can feel it, palpate it easily. Yes, if it is a small mass and you're unsure, yes, you can take the help of an ultrasound guidance. So you are looking for a core needle biopsy. When you do a core needle, what are the informations that you would like to have in the report of your core needle biopsy?
I would like to know whether this is a malignant, and if malignant, whether it's a ductal carcinoma in situ or invasive. By IHC marker, I would like to know the ER, PR, estrogen receptor status, progesterone receptor status, HER2 receptor status, and Ki67 index.
So you would first like to know the histopathology, you would like to know the grading, you would like to know the immunohistochemistry, which will help you bring about a diagnosis about the molecular subtyping. These are the 4 informations that we look for when we do a core needle biopsy. What else would you like to do? Would you like to do any imaging? You said you would complete your triple assessment. So what imaging would you like to do in this case?
I would like to do a mammogram, ma'am, both the breasts, to look for multifocal disease and also whether if there is involvement for the other breast.
Absolutely. So you're going to do a bilateral mammogram. 65-year-old lady, you're going to do a bilateral mammogram. Not only will you see the affected breast, you're also going to examine the opposite breast and axilla in the mammogram. Okay. So as far as the staging of the disease, you had said that it is probably a stage 3, or after chemotherapy, it's come down to a lower stage. What other investigations would you like to do? Any other workup you would like to do before you plan your treatment policy?
I'm sorry, ma'am. Any other, what was the question?
You would like to do before you plan your treatment?
I would like to rule out metastasis, ma'am. I would like to do ultrasound abdomen and CT chest, and that's it, ma'am. Because patient is not having any bone pain, so I would not go ahead with the bone scan. If patient complains of bone pain, I would go ahead with bone scan.
If you're doing a CT chest, why not a CT abdomen as well? We'll put the patient in the gantry, get both done. I think the NCCN 2020 guidelines very clearly says that a metastatic workup includes a CT chest. Yes, we always do an ultrasound upfront. That's the first thing we do, and the chest X-ray obviously. But in a metastatic workup, it says we do a CT chest and abdomen with pelvis, and you may do a bone scan. A brain CT is to be done only if there are symptoms suggestive of a brain met. So on a routine basis, we are not going to work up with the brain. I think Dr. Kanagavel wanted to say something.
Madam, I think Madhuri ma'am is back with us. Madhuri ma'am, you would like to ask some questions, ma'am? Madam, I think we still have the same issue, ma'am. Do you have any other device to log in, ma'am? We could see you well, but unfortunately, we are not able to hear you, ma'am. We are unable to hear you, ma'am. I would request you to join either from your hand phone, mobile phone, or any other device, ma'am, that usually helps us. Or use a headset, ma'am. Please. Or maybe you disconnect the headset, ma'am. There is some mismatch between your headset mic. Now you try, ma'am.
Is it?
Yeah, perfect, ma'am. Perfect. Please go ahead.
Can you hear me now?
Very well, madam. Finally, yes.
Okay. No, I was just about to say about the bone scan, because that is mandatory. Only X-ray will not reveal metastasis in the bones. Bone scan is an essential component of workup for these patients.
Okay.
I think a lot of examiners will want to hear you say PET scan, because there are a lot of people who still believe that you, instead of doing a chest, abdomen and a bone scan, why not get away with a single PET scan? But as far as the exams go, I think it is best to stay on to the NCCN guidelines, because PET has not yet come into the NCCN.
That way, some people believe in doing PET straight away, but that is not what is recommended.
Yes, absolutely, ma'am. Absolutely. I think you stick to chest CT, abdomen and pelvis CT, and a bone scan. That should complete your metastatic workup.
Yeah.
Okay.
Yes.
You've done a metastatic workup and your patient is M0. Okay. So
Yes, ma'am.
how would you plan your therapy for this patient now?
This patient, I would like to go.
That you do not know about this NACT. This is an upfront patient. How would you plan your therapy now? What are the components of therapy and how will you sequence them?
I would like to discuss in a tumor board, ma'am. Then I would suggest for going in for the upfront surgery, ma'am, followed by chemotherapy and radiotherapy. And if PR positive, hormone therapy. And if the HER2 is positive, also I like to give.
So you want to
Targeted.
offer her upfront surgery. What is the reason behind this decision? What is your rationale behind this decision?
Because it is a early breast cancer and it is operable.
I think it was a T3N1. That's what it was before the chemo. So I said, don't please ignore the post-chemo status. If the patient came to
in that case,
yeah.
No, ma'am. In that case, I would like to, if there is T3N1, I would like to go ahead with the neoadjuvant chemotherapy, followed by surgery, followed by chemotherapy and RT and targeted therapy, ma'am.
Okay,
Can I intervene? I think the concept of giving neoadjuvant chemotherapy 3 cycles, 4 cycles, and then surgery, and then again followed by chemo is given up now. All cycles of chemo are given before the patient is taken up for surgery. And then you reevaluate to see whether now the patient is or patient has responded and is ready for surgery now. You don't divide the chemotherapy because you don't want to waste time in surgery, wound healing, everything. You give all the chemo to start with.
Absolutely agree with ma'am. But the only point is, provided the candidate is responding to the chemo.
Yes.
If that the patient is not responding to it, there is makes no sense that you continue for the 6 cycles. In that case, you might stop, either change your regimen, or surgery, and do the rest of it on a different regimen post surgery.
Yeah, changing the regime is preferred probably.
Absolutely. Do you think NACT gives you any other advantage other than, as ma'am said, that there is a wastage of time in wound healing, so the treatment gets delayed? Any other advantage? Does it give you any survival benefit? NACT,
no, ma'am.
CT, adjuvant CT?
No, ma'am. Actually, there is no overall benefit from neoadjuvant or adjuvant, ma'am.
Say there's no overall benefit.
There's no overall survival.
Yeah. So there are 2 things you have to look out for. One is called the overall survival, and the other is called the disease-free
pathological
OS and a DFS. So in the OS and DFS, there is no difference between neoadjuvant versus adjuvant therapy. So, but then we still go ahead with the neoadjuvant therapy. So why do we? If there is no benefit, then why are we going through the neoadjuvant chemotherapy?
Ma'am, the advantages of neoadjuvant include early initiation of systemic therapy, ma'am. And if we can downsize the tumor, thereby improving the better clearance, and by starting the chemotherapy with the intact blood supply, and we can also see the in vivo chemosensitivity of the tumor.
Right. So it makes the tumor more surgically easier to take out, and definitely we get to know the in vivo response of the tumor to the drug that we are using. And if there is poor response, we can think of a switch in the regimen.
And Arjun, maybe one important other point you can add that some of them may ask for a breast conservation after, if there is a good response. So adding on to this question, will you do that in your patient now? Suppose I ask you this question.
No, sir. I would not do that in my patient because it is a multifocal disease, which is a contraindication for breast conservation.
So now that you have given chemotherapy, neoadjuvant is over, you are feeling 2 lumps. One on the outer aspect, another is just below the retroareal, no, according to you.
Yes.
So your patient is definitely not a candidate for BCS at this juncture. That is what probably examiner will definitely ask you in your patient. Okay, please continue, madam.
Do you know what is the Hostadian concept of breast cancer, what we are talking about, the chemotherapy, upfront surgery. Do you know what is Hostadian concept and what is the Fisherian concept?
Yes, sir. Halstadian concept is William Halsted initially said see a breast is spread by the loco-regional spread, and Fisher theory says from the outset see a breast is a systematic disease.
Right.
Systemic.
But
Systemic.
the cancer breast can go both ways.
Yes, sir.
So both are not correct. Both are only partially correct. So what is the concept now?
Spectrum.
Yes, the spectrum concept.
Spectrum.
Spectrum concept says that cancer breast can go like the Hostadian, or it can also go like the Fisherian. Okay. So that is the reason that you take advantage of carrying out the surgery and the chemotherapy. Because you are thinking it's a systemic disease, so you are giving the patient the chemotherapy. You are thinking it's a loco-regional one, that we are going for the surgery. And that is why even in the locally advanced breast cancer which is there, if it is operable breast cancer, people have started saying that there is no need for going for the neoadjuvant chemotherapy, which was always there few years back. So you can go for the upfront surgery in a operable breast cancer. It should be operable breast cancer, and then you can follow it with the adjuvant chemotherapy. Okay, so that scenario is changing now. So this is based on these concepts that cancer breast is a bimodal pattern which is there. You know what is the tumor doubling time for the breast cancer?
Sir, approximately 90 to 120 days, sir.
So to make a tumor 1 centimeter palpable, how much time does it take?
Approximately 5 years, sir.
That's right. Approximately 5 years it takes. Yeah, you're right. Okay, go ahead with Dr. Shamita, please.
Your patient has received 8 cycles of chemotherapy, you said, right? Now, if you are planning neoadjuvant chemotherapy, the sir was just saying that this patient is definitely not a candidate for BCS. But if your patient is interested in breast conservation and you're giving NSCT with the objective that if this patient satisfies the criteria, I might proceed with a BCT, then would you like to do anything else when you're planning your neoadjuvant chemotherapy? Would you like to do anything to assess the regression of your tumor? How much?
Yes, ma'am. Yes, ma'am. I would like to do both clinical examination as well as imaging, preferably mammogram.
So that you are doing when you are giving your chemotherapy, either at the onset or maybe after 1 or 2 cycles. Would you like to put a marker to see whether the regression is occurring or not?
Yes, ma'am.
Yeah. Because you have negative patients who respond very well to the chemotherapy, and you may, as ma'am was saying, that you usually complete all the cycles, and the end of all your cycles there may not be any lump felt. So you have to put a mark if you see your patient is progressing well with chemotherapy. Okay, so usually we put a marker after the 2nd cycle depending on how she is progressing, so that we can monitor the regression in size, and in the case of a complete pathological response, we know where the nidus of the tumor was, the heart of the tumor was, so that we can plan our surgical excision accordingly.
Yes.
Yes, sir. Anna?
Arjun, if you have forgotten to put the markers and there's a complete response is there, how will you plan your surgery now?
I would like to remove the whole quadrant, sir.
Okay, so that is one. But the patient says that, no, I just really want to have only the breast conservation. Then can you from any investigation that probably this is the place where we should go for the breast conservation?
I'm not aware, sir.
Okay.
No, you can do the mammography, okay? If you remember that always in the breast cancer, there are micro calcifications which are there. And it has been usually seen that even after giving the chemotherapy and with the complete response, those micro calcifications which are there, they may persist in that area. So you can pick up on the mammography or the MRI, those micro calcifications which are there, and you can plan your breast conservation in that area. Apart from doing quadrectomy, what you said, that is also right. But you can also do it like this way also.
If you only see the microcalcifications and clinically no lump is palpable, how would you surgically plan your excision of that place? Clinically, nothing is palpable. Your master's mammography as Sir said, that the mammography shows the cluster of microcalcifications. So how are you plan your surgery to take it out? Take out that area?
If there is diffuse calcification, I would go ahead with the MRM, modified radical mastectomy.
There is a cluster of microcalcifications, which is basically the footprint of the tumor that was. So now you want to take out that area, but it's not a clinically palpable thing. So how would you proceed? Patient wants a breast conservation.
I think some de novo patient comes to you with a routine mammogram, you pick up some calcification, you want to get a histology, what will you do? Can you do something now in the radiology department and then take them? That's what I think is the answer Madam is expecting. Can you do something?
Wire-guided localization. You can do a wire-guided localization in the radiology department, shift the patient to your theater and excise the area which is through which the wire is passing, the heart of the wire is passing. So that can help you take out the affected area.
Arjun, when you're doing the breast conservation surgery, what are the margins you take?
Around 1 centimeter margin around from the tumor, sir. Circumferentially, about 1 centimeter clearance.
1 centimeter cross margin.
Are you going to excise the skin along with that?
No, no, sir.
And
so how do you label your specimen?
Sorry, sir?
How do you label your specimen to be sent to the pathologist?
Sir, short superior and long lateral, sir. The orientation.
And how the pathologist to know which is anterior, which is posterior? You know, you have to see for 6 margins here, okay? Superior, inferior, lateral, medial, anterior, posterior. So what you said rightly is short superior and the long lateral, but what about the anterior, posterior?
Tattooing, sir, in the anterior border. Anterior.
Or you can just take a very small, millimeter of skin on the anterior side. So that will become the anterior margin there, no?
Okay.
There is another simpler way of doing it. It's double deep, meaning on the deeper aspect, that is the posterior aspect, you put 2 sutures. So double sutures. S for S, short for superior, long for lateral, LL, and DD, double for deep. If you obviously have a skin paddle, this will not be relevant. But if, as Sir said, if you're taking out just doing a lumpectomy with a 1 centimeter gross margin, then you can put a double deep as well. Okay.
Okay.
Right.
Now there's a big defect is there. So what are you going to do for that defect?
I would like to do reconstructive surgery by, I can either use the nearby latissimus dorsi mini LD flap, and or I would like to use tram flap or deep inferior epigastric flap. So this we can do at least by volume replacement and volume displacement.
In both cases, you will not do the flaps, volume replacement and displacement. In which case are you going to, and these flaps have to be pre-operatively planned. It cannot be an on-table decision, right? So when will you plan these flaps? What percentage of breast tissue loss will help you decide that this is what I'm going to do?
More than 30, I'm not sure, ma'am.
20%, right? If it is less than 20% volume, we can do a volume displacement, okay? But if it is a larger than 20% volume, we can plan a volume replacement, which can be in the form of a local muscle flap, or even an implant-based reconstruction, whatever. So I was asking you about the margin. You said you will keep a 1 centimeter margin. Now, when
on that basis, I like to ask you, how can you confirm that your margins have R0 dissection?
frozen section.
Yes.
With the frozen section, I would like to confirm.
Yeah, you had to, and while sending that specimen for the frozen section.
You know what is inked margin?
Ink margin, it's negative. So the margins are negative.
So you have to put the ink. Okay, you have to put the ink there, and also you have to put the in the base and surrounding. You have to put some markers for the radiotherapy. Okay, so these are extra things has to be done when you are doing the breast conservation surgery.
How will you
sorry, ma'am, go ahead.
How will you decide about whether you will go for axillary dissection or not?
Actually, if the patient has presented with the N1, I would like to go ahead with the axillary dissection, ma'am. If the patient was N0 from the beginning, I would like to do a sentinel node biopsy. And if that is positive, I'd like to go ahead with the axillary dissection.
But many of the times you may not be able to palpate if the obese patient is there. So you may not be able to palpate even if the lymph nodes may be actually enlarged or maybe having disease.
I would like to do the ultrasound of axilla, ma'am. If ultrasound axilla, it's whether it's positive or not, we'll be able to guess.
That is one thing. And sentinel.
Arjun, what are the various ways to carry out the sentinel node biopsy?
Sir, it can be done previous to the surgery. 1 day previous to the surgery, we can inject the technetium radiocolloid scan, radiocolloid dye, and or it can also be injected just before the surgery or even during the intra period by using a colloid sulfur. Sir?
Blue hot nodule, okay.
Yes, sir.
Okay. Blue because of dye. You know what is the other dye which is being used nowadays?
Isosulfone blue.
That was there before.
Some other color, non-blue color?
I don't know.
You know, nowadays there is a very popular green dye is there.
Indocyanine green.
Yeah, it is almost being used at every place now. There is no place in the body where it is not used. So you can use the same dye here also.
If you're planning neoadjuvant chemo, your patient is upfront N0, and as you were discussing just now, you plan to do a sentinel lymph node biopsy. If you are planning neoadjuvant chemotherapy, will you do the sentinel lymph node biopsy prior to the onset of neoadjuvant or after the neoadjuvant has been done at the surgical table?
I would like to do it prior to the neoadjuvant.
Because often, as sir said right at the beginning, your staging will be what it was prior to therapy. So if it was N0 at that time and you are in doubt, you can do a sentinel lymph node biopsy. Yes, the completion of ALND or whatever you want to do will depend on whenever you take the patient up for surgical intervention. Your patient has completed her 8 cycles of neoadjuvant chemotherapy, and her IHC has come out to be ER/PR positive, HER2 negative. So what hormonal therapy would you like to give her?
As the patient is postmenopausal, I would like to go with aromatase inhibitors.
What aromatase inhibitors would you like to give her?
Anastrozole, letrozole, or letrozole.
Okay. How long would you like to give the anastrozole? She's 65, you said, right?
Yes.
How long would you like to give the anastrozole?
Ideally, now the preferred is for 10 years, ma'am. But if the patient, I would like to, after starting aromatase inhibitors, I would like to follow up and see if there is any involvement of the bone. If there is disturbance with the bone or bone pain or osteoporosis, I would like to switch over to tamoxifen after 5 years.
If it was a premenopausal lady,
If it's a premenopausal lady, I would like to start with tamoxifen 20 mg BD for 5 years, ma'am.
I think the recommendations now are that if it is a premenopausal lady, you can, obviously it was always that tamoxifen for 5 years. Then they progressed it to 7 years. Now they are saying that you can always continue for 10 years, obviously keeping the side effects in mind. But usually in the 10-year duration, these ladies either pharmacologically or otherwise also they might attain menopause. So once they attain menopause, you might consider switching to a aromatase inhibitor. In your lady, since she's right away, she's post-menopausal, you can start aromatase inhibitors directly. You can continue for up to 5 years, not more than that. After that, if she's still maintaining, requiring adjuvant therapy, you might switch to tamoxifen even in post-menopausal women. What are the precautions and what are the things that you look out for in long-term hormonal therapy? Any side effects that you have to be aware of?
In case of tamoxifen, I would like to follow up with the ultrasound to look for the endometrial hyperplasia, which is a side effect. And in case of aromatase inhibitors, I would like to do a bone scan.
Bone scan and also a regular cardiac evaluation. Right?
Yes, ma'am.
Particularly, see, she's 65. She would all, as it is, be having osteoporosis. She might be having cardiac comorbidities. So these need to be followed up because often patients on long-term aromatase inhibitors might have cardiac malfunctioning at some time or the other. Now, if you are offering chemotherapy and hormonal therapy, both are systemic therapies. So would you like to give it together or would you like to sequence it?
Ma'am, I would like to sequence it, ma'am. I would like to give chemotherapy first, followed by hormonal therapy, ma'am.
Why is that so? Can we not give it together? I'm just asking, can we not give it together?
It's because of the toxicity, I think, ma'am. Patient
Is it
it's better
toxicity
off.
or is it the mechanism of action that is so very different that we don't give it together?
Mechanism of action.
What is the, see, in what happens in chemotherapy? Chemotherapy, if you think of the cell phase, the G1, S, G2, that cell phase, the chemotherapy usually acts on the G2 phase, right? So the G2 phase meaning that just prior to mitosis. So we want the chemo to act on the dividing cells. But the hormonal therapy that acts on the G1 phase, that is the growth phase. So the actions are on two different times of the cell phase. So giving them together will not give them equal benefit. So we usually complete the chemotherapy and then we sequence the hormonal therapy. Where would you fit in the radiotherapy in this case? If the when do you think a patient will require radiotherapy? Let's come to that first.
If
Which
for
patient will require radiotherapy?
Any T3, T4 lesion, and if the post-surgery, if there are more than 4 nodes involved, if there is a margin of less than 1 centimeters, or if the margins are positive.
Right. Anything else about the nodes other than just the number? You said more than
Lymphovascular invasion.
Lymphovascular invasion, perineural invasion, also extracapsular spread in case of the nodes. If the disease has gone beyond the capsule of the node, then definitely you have to think about radiotherapy. So in this sequencing of your patient had neoadjuvant, now she's undergoing surgery, where do you put in the radiotherapy?
After chemotherapy, ma'am.
So the radiotherapy and the hormonal therapy can coexist, can be given together. But remember that the chemo and the hormonal therapy should not be given together. Sir, I think you want to add.
Why the nails are black in your patient?
I think it is a adverse effect of the chemotherapy, sir. The cyclophosphamide is associated with skin pigmentation.
What are the other drugs which can cause the pigmentation? Chemotherapeutic drugs? Apart from the cyclophosphamide?
Not sure, sir. Vincristine.
5-fluorouracil can cause it. The bleomycin can cause it. Okay. And that is why sometimes we have seen that even if we are giving the bleomycin for our vascular malformation cases, the patient may develop the black pigmentation. So we tell those patients that there may be the black pigmentation. Even for a benign lesion, the vascular malformation, if you are giving the intralesional bleomycin, it can cause the blackish discoloration.
Arjun,
Yes, sir.
your patient has undergone neoadjuvant chemotherapy, and
Yes, sir.
next plan is, if I not mistaken you are going to do MRM, correct?
Yes, sir.
Now, what is the next thing you do?
After MRM, I would go ahead with radiotherapy.
So
And
that's what I wanted to have a clarity on that. So you give the radiotherapy after the MRM. Why you should give? Where you will give?
Sir, I would like to give to the chest wall, sir, to address the level 3 axillary and infraclavicular and supraclavicular region, sir.
So that is the area which you are not covered. Anything else you are not covered during your MRM or whatever internal mammary area region. So
yes, sir.
You said no retroaerial or going to medial side or whatever it is. So you are going to give a radiotherapy, and then what? Then what for this patient post-menopause?
Hormonal therapy. Hormonal therapy, sir.
Yeah, like what? What is the choice? If she is, let us say,
aromatase inhibitors, I would like to give, sir.
Drug dosage at least 1 or 2 you should know.
Yes, sir. Anastrozole or letrozole.
Khanna sir and Rajgopal sir, can we close this case, sir? Can we go to the next case, sir?
Yeah, we can go.
Sure. Shamita ma'am, would you like to add something more, ma'am? Madhuri ma'am?
I think more or less covered.
We have taken him to oncology exam.
Ma'am, this is a sort of a teaching model only, ma'am. So the students are definitely given more time to discuss. So beyond the clinical things, we also take them on the operative side and the management side and a little bit on the complication side also, ma'am. So they have a little longer. This is definitely not limited with the 20-30 minutes focus, madam. So it is always a little. Yes, madam.
We should have asked some more questions on operative plan and complications and all that instead of chemotherapy, because nowadays everything is managed by chemotherapist only.
But they do get theory questions on the management of drugs as well, madam, because ma'am, definitely there are always scope to ask different questions, madam. Definitely, I'm not denying that. But I think today's focus, we will definitely have one more case and we will concentrate on the operative surgery, ma'am, for sure.
Yes.
I would always like to give the candidate to have any doubts to be clarified with the senior faculty here. Dr. Arjun, do you have any clarifications or any doubts you want to clarify with the senior examiners?
No, sir. I'd like to thank you and thank all the professor for this chance, sir. Thank you, sir.
Thank you, Arjun. My kind enquiries to Professor Ibrahim, sir, and your chief. Thank you, Karnakaran, sir, for permitting this boy to present the case here. Thank you. Thank you. Now I'd like to invite Dr. Swarna Varsha to share her
best wishes, Arjun.
Dr. Swarna, are you with us?
Yes, sir. Yes, sir. Can you hear me, sir? Good evening, sir. Good evening, everybody.
You are good to go, but we are yet to see your PowerPoint.
Is it shared, sir, now?
Not yet.
1 second, sir. Now, sir?
No, ma'am, we are unable to see your PowerPoint.
Just a second, sir. So, are you able to see, sir?
No, ma'am.
1 second, sir.
Madam, I have a question to Samita, madam, and Dr. Srinivasan from Coimbatore. Samita, madam, if the student says neoadjuvant chemotherapy followed by radical mass MRM with post-adjuvant chemotherapy. Is it accepted, madam? As Professor Madhuri madam said, now we are in the new concept. But can we?
Sir, it is acceptable. Neoadjuvant chemotherapy followed by surgery followed by adjuvant chemotherapy. Now the next question obviously will come to how many before and how many after. These are the traditional questions. We prefer to give all the cycles upfront if the patient is responding well. If somebody is not responding, then only we halt it in between. Otherwise, the preference now is, sir, that you continue. The 3 cycles before and then surgery followed by 3 more is not accepted anymore. You give as many cycles as possible, provided the patient is responding to the chemotherapy.
Okay, thank you, ma'am.
Because we do have radiation to be given later on again.
Right, right. If the patient is responding, so the answer will be, I will continue to give all the cycles as long as the patient is responding.
Yes.
And in between, I'm going to clinically and also with imaging, evaluate the response of the patient to the chemotherapy. That is what we would like to hear.
Thank you, madam. Kanawal sir, please. Thank you.
I think we will invite Dr. Swarna to start her presentation. Dr. Swarna, over to you, please.
Yes, sir. Good evening,
Switch on your video, Kana.
One second, sir.
Yeah. Yes.
Yes,
Go
sir.
ahead. Good luck. Yeah.
Yes, sir. Good evening, everybody. I'm Dr. Swarna Varsha, second year DNB General Surgery Resident at St. Isabel's Hospital, and we will be discussing a case on right iliac fossa mass. Mr. X, 29-year-old gentleman, postgraduate IT employee from Chennai, complains of pain abdomen, right lower quadrant since 1.5 months, altered bowel habits since 1 month. History of presenting illness. 29-year-old gentleman was apparently well 1.5 months back. Then he developed pain abdomen, right lower quadrant, which is insidious in onset, gradually progressive in nature, dull aching type of pain, moderate intensity, aggravated after 1 hour of food intake. And also the nature, he also gives history that the nature of the pain changes to colicky type, which relieves on taking painkillers, especially he takes tablet Drotin for pain relief, and no history of pain radiation. He also gives a history of altered bowel habits in the form of loose stools, 5 to 6 episodes per day, watery and fecal matter, which is yellowish in color, no passage of mucus, streaky blood, constipation, bleeding per rectum, or any tenesmus. He also gives history of loss of weight, 4 kgs over 45 days, with a history of loss of appetite and generalized weakness since 40 days. No history of fever, no history of difficulty in walking, no history of vomiting, no history of obstipation, no history of any contact with TB, no history suggestive of any metastasis. The histories which I have asked for metastasis are any history of abdominal distension, melena, jaundice, that is yellowish discoloration of sclera or passage of high colored urine, hemoptysis, hematemesis, low backache, headache, syncope, and seizures. Medical history is not a known case of hypertension, diabetes mellitus, hypothyroidism, epilepsy, or any other chronic illness such as tuberculosis which warranted medication. Surgical history, he underwent lipoma excision 10 years back in the right scapular region. Treatment history. He was evaluated for the above complaints, for which he was advised ultrasound abdomen, which revealed some pathology which he told to be a mass in the intestine, which warranted a CECT abdomen, which revealed eccentric wall thickening involving the terminal ileum, ileocecal junction, cecum, and ascending colon with multiple enlarged mesenteric lymph nodes, which with features of Cox. Colonoscopic guided biopsy was done, and which revealed an ulceroproliferative lesion in the ascending colon cecum, which was biopsied, and histopathology revealed poorly differentiated malignancy suggestive of lymphoma. They also had sent for gene expert, which revealed negative reports. IHC panel was sent, and reports are awaited. Family history: no history of TB in the family, no history of any GI malignancy in the family. Personal history: diet. He is a mixed diet. He takes mixed diet but prefers non-vegetarian diet. Occasional smoker, non-alcoholic. Married life is 1 year with no children. Bladder habits are normal, and bowel habits, as in history described, it was altered, which is in the form of loose stools. Coming to the summary of a case. 29-year-old gentleman, IT employee from Chennai, married for 1 year, has come with complaints of pain, abdomen, right lower quadrant, and altered bowel habits, whose duration is since 1 to 1.5 months, with history of anorexia, significant weight loss, no history or suggestion of any metastasis, or with no history of TB, no history of any comorbidities, and status post lipoma excision, who is also an occasional smoker.
Hello.
Hello.
Yes, Savarna.
Yes, ma'am. Yes, sir.
What is the significance of lipoma, excision of lipoma 10
Sir,
years back?
It was told to be benign lesion, sir. It is not a malignant lesion, and that is the only significance, just for the completion of the history.
Swarna,
Yes.
you are presenting this case in the examination. We don't give details about the investigation. Like CCT, here you have written everything, and you have written about the colonoscopy and all that. So
Yes,
in examination, we don't provide. Yeah, we don't provide any investigation and its report. So actually, you should not have presented this case like this, because there is no question of putting the differential diagnosis when you have given a biopsy report, CT scan, everything. It is proved case now.
Yes, ma'am.
And differential diagnosis comes at the end of your clinical examination, not at the end of history.
The summary.
Yes, ma'am.
So I
Yes,
think actually this should be now the case is clear that this is a case of malignancy and all that.
So we can start this as a tumor board discussion, madam.
So for some kind of a discussion for postgraduates, I think we should take on to her. Go back to the first slide, Doctor. Yeah.
Yes, sir.
When this, whether it's IT or a doctor or a lawyer or somebody, when the word 29-year-old with the pain and altered bowel habits come, what is with the 1.5 months duration? Just give me 2-3 diagnoses at this stage. First slide.
Sir, 29-year-old, first thing, it could be ileocecal tuberculosis.
Accepted.
Second thing, it could be an appendicular pathology.
Don't bring pathology and all that thing at this juncture. Just be specific to the 2 complaints only. Only 2 complaints: pain and altered bowel habits.
Yes, sir. Ileocecal tuberculosis. Second one is any right-sided colonic mass or any colonic mass.
That is not accepted. Pain, abdomen, altered bowel habits. You are told tuberculosis, accepted. Second, be specific. Try to think in that direction. I will ask you, why not?
Any medical conditions?
Why not Crohn's disease? Suppose I ask you this question.
Inflammatory bowel disease.
Say that. Say that. Anything else you would like to think of? Only 2 complaints, no? Pain and altered bowel habits. So you need to think that it is intestinal pathology. You need to think of he is an IT person. You need to think of he is traveling here and there too much. So anything else you would like to consider?
Some amoebiasis, any
recurrent typhlitis. Recurrent typhlitis.
Or GRDSS.
So this is how the mind should work at this stage. The first introduction itself, as you see this patient who is walking to your office or wherever it is. Can we continue, madam? I think you please take over, madam. Invited faculty, please. So that we'll treat this as, we don't know the diagnosis. We'll treat like that. We don't know lymphoma.
Yeah. Go to the next slide.
Yes. Yes, ma'am.
Here, you said that his pain was relieved. It was colicky type of and was getting relieved with the painkiller.
Yes, ma'am.
Okay, so tell me, so what else you can put as a differential diagnosis at this place? Adding to your this history.
Yes, ma'am. Colicky type, it can be ileocecal tuberculosis.
Okay.
One, and second thing can be right lower quadrant pain. It can be even mild appendicitis.
For 1.5 month, the history is of
It
1.5 month.
It will be acute, ma'am. And
say intestinal pathology.
Intestinal pathology.
And before I forget, don't say painkillers. There's nothing which is killed here. Say,
Yes.
Just say simple analysis.
And don't write the drotin and all that like this, because again it's a trade name, na? Drotin is trade name.
Yes, sir. Yes, ma'am.
You can just write down that he was taking some painkiller for relieving that pain.
Okay, ma'am.
Okay, go ahead.
1 second, ma'am.
Okay, go ahead. Because already you had told about the diagnosis, na? There is so many questions which I have left to add. I think go for the examination.
But just tell me that, can it still have anything to do with lipoma on the back that was removed?
Just she must have added as a surgical history, I think.
Yes,
yeah, but patients who have lipoma on the back, patients, or particularly if they have multiple lipomas, lipomatosis, this still can be a retroperitoneal lipoma.
Yes, sir.
If you keep aside the bowel complaints.
Yes, ma'am.
Okay, go ahead. General examination.
Yes, ma'am. Shall I start, ma'am?
Yeah.
Patient is conscious, cooperative, alert, well-oriented to time, place, and person. Thin built, moderately nourished. ECOG score is 1. Weight is 65 kilos. Height is 175 centimeters. BMI is 21.25 kgs per meter square. No pallor, no icterus, no clubbing, no cyanosis, no lymphadenopathy, no edema.
You said he has lost weight. Is it a significant weight loss?
Ma'am, he says 4 kgs in 45 days. He has lost.
So is it significant?
It is significant, ma'am.
What is significant?
Basically, significant weight loss is more than 5% of loss of body weight in 6 months duration. But he gives a rapid weight loss in 45 days itself. So it should be significant weight loss.
Okay.
Oral cavity is normal. Spine, back, scapula, pelvis appear to be normal. No tenderness on deep palpation. 4 by 1 centimeter.
In general examination, do we check oral cavity?
Ma'am, if I want to see Hodgkin's lymphoma or any lymphoma, tonsillitis, any such thing, I can check the oral cavity. And for oral hygiene and any melanomatous depigmentation of the mucosa.
I think.
And also pallor.
Do you agree, Madhuri madam?
I think this pallor I agree, but then that is just tongue and conjunctiva that you would see. This specific examination of oral cavity would probably come if you find lymphadenopathy in the neck, or you find any evidence of lymphoma. Don't come to oral examination because now you know that the histology has been lymphoma.
Yeah, he has prejudiced about the lymphoma.
So she is trying to kind of go back to her.
Why do you have this idea in your mind, madam? Why do you have this idea, this transformer? Any in the previous history of lipoma excision, you think it's a lymphoma like that?
No, sir, it was a benign lipoma.
Then you have some idea behind in your mind, like lymphoma also one of the diagnosis.
No, sir. General physical examination to see the tongue, anything, any tonsillar fossa, any redness or any inflammation is there, all that to see.
Okay, go ahead.
Neck is normal. Bilateral supraclavicular fossa normal, no lymphadenopathy. Vitals, pulse rate is 80 per minute.
It is usually not, you should not say neck is normal. So we usually check you are already written. No pallor,
no lymphadenopathy.
That's over.
Yes, ma'am.
Because it is everything is prejudiced now. So many of the times, if you are giving some exam, the examiner will come to know that you know every report, you know investigation of this patient and all that.
And another thing is you are investing too much time in this. See, here we can take exam for 1 hour, but that is not the true situation when you are appearing for exam.
Yes, ma'am.
Yeah.
So don't waste time.
Yeah. Unnecessary things, weight, height also, I think it's not taken into account for general examination.
Yes, ma'am.
Unless we are planning some bariatric surgery or something like that.
And I think this pulse rate, BP, respiratory rate should come much ahead in the beginning.
Ahead, yeah.
And then
In
you
the
talk
beginning.
about pallar, icterus, clubbing, etc.
LR, yes, yes. SpO2 now is also again okay.
Okay.
Okay, go ahead. Go to the per abdomen examination.
Systemic examination per abdomen, inspection, all quadrants move proportionately with respiration. Umbilicus is midline, appears normal. No visible mass noted. Bilateral renal angle appear normal. No distension, no dilated veins, visible intestinal peristalsis. No cough impulse noted. No scars or sinuses seen. Hernial orifice is intact. Skin appears normal. No erythema noted. Palpation, no local rise of temperature, soft, non-tender, no guarding rigidity, mass palpable over the right iliac fossa with extension into the right lumbar region of size 6 by 5 centimeters. Medial border is palpable 4 centimeters from umbilicus. Superior border is palpable 15 centimeters from the right costal margin at the level of mid-clavicular line. Lateral border is palpable 3 to 4 centimeters from right superior iliac spine. Anterior superior iliac spine. Lower border is palpable 3 centimeters from the groin crease. Surface is nodular, hardened consistency. It is an intra-abdominal mass which is not prominent or head rising or leg rising, and it moves forward or knee chest position. Mobile only in transverse direction, not and very limited, very limited mobility vertically. So I've written not vertical mobility. No palpable.
Excuse me, Suvarna, have you got a photograph of this patient? Have you put the photograph here?
No, ma'am. I don't have the photograph.
Okay,
but I have
because
drawn.
It's just you are drawn. No,
yes,
because the size of the lump is, you said 6 into 5 centimeter. Appears to be a large lump.
Yes, ma'am.
Which it should have visible. I think you said nothing is visible and all thing. 6 centimeter is a large size. So I think I don't know. You have not put the photograph, so I can't comment on that. But 6 centimeter is a large size. Should have been visible on the per abdominal examination on inspection.
Not visible, ma'am. No distension, no visibility.
Okay, I mean,
was flat.
we can't really argue on that because we can't see the patient. Yeah.
Yes, ma'am.
Okay, go ahead.
No distension, no free fluid. Hernial orifices are normal. Percussion, dull note over the mass. Liver spinous from 4th intercostal space to 5 centimeters below the costal margin. On the right side at the level of mid-clavicular line. No free fluid. Tympanic note noted all over the abdomen except over the mass. Auscultation, bowel sounds are heard. External genitalia normal, uncircumcised. Bilateral testes and parts palpable and normal. Scrotum is normal. Meatus is normal.
Are you able to hear any hyperperistalsis or bowel sounds are normal?
Normally heard, ma'am. No hyperperistalsis. Okay. And history-wise also, he didn't give any history of obstipation or constipation or not able to pass.
He gives history of pain, isn't it?
Yes, yes, ma'am. Yes, ma'am. For rectal examination, normal skin, no sentinel tags noted, no swellings, no spasm, sphincter tone is adequate, mucosa appears normal, watery liquid stool stain during the examination, no bleeding or streaky blood tinge noted, prostate is normal, no nodularity, no deposits felt.
So sphincter tone is normal, not
yes,
adequate.
Yes, yes, ma'am.
Do you feel the lump on per rectal examination?
No, ma'am, I couldn't feel the lump on per rectal examination.
Okay. I mean, I'm not saying that you should feel the lump on per rectal examination in rectum. I'm trying to ask you whether through the rectal wall you could appreciate the lump on the right side.
No, ma'am, I couldn't appreciate.
Okay.
No nodularity also felt.
Okay.
Dr. Swarna,
Yes, sir. Yes, sir.
anything else in the rectal examination? Is it the feeling lump is important or anything else?
No deposits.
Which deposit you are talking about? Where is the deposit?
In the rectovesical pouch.
What deposit is that?
Blumbox.
No. What exactly you mean by that word deposit?
Any nodularity, nodular feel, or any peritoneal deposit.
Shelf, shelf.
Shelf, Bloomer shelf.
How you said Blumberg or something? I think
Bloomer shelf.
So
Bloomer shelf.
Like a shelf. No, I think the answer I wanted was blood and mucus. See, your patient has been having altered bowel habits. That
Yes,
is
sir.
what you started with, no?
Yes,
your
sir.
patient is having altered bowel habits from the time you have been telling. Young
Yes, sir.
patient. So we
Yes,
would like to rule out in a rectal examination for any blood and mucus.
Yes, sir.
That will take the first priority.
Yes,
Okay.
sir.
The second comes the sphincter tone and all that which you are talking about. Then rectovesical deposits.
Yes,
Do
sir.
you expect any prostate thing in it?
No, sir. No, sir.
In this case, now, if you don't find anything, you can say that on per rectal examination, no significant
That's all.
finding.
Easy.
Yeah. Instead of telling all this now and expanding your case history like this.
Yes, yes, ma'am.
And if examiner asks you what significant findings you expect, then you can tell that mucus and this thing and all that.
Yes, ma'am.
Okay.
One second.
There are one or two other things I would like to answer. I'm not sure whether it's been clarified. Just to clarify, a knee elbow test. Do you think a right leg fossa? It's a
actually mesenteric mass if you are suspecting.
So generally, people have stopped putting the patient on knee elbow position. Number one. If you have got a
very uncomfortable.
Yes, retroperitoneal mass, you can put on side. Side. You can maybe a left lateral, right lateral to check for the mobility. And right leg fossa, left leg fossa, hypochondric mass, where the space for them to fall forwards, there's nothing there. Okay, I think it is not required. You are basically, you just say intra-abdominal mass. Intra-abdominal mass, whether it is intraperitoneal, retroperitoneal, because it is in the right leg fossa, with you have got some mobility. No, you said some mobility is present.
Transverse mobility and limited vertical mobility.
So keeping that in mind, you have got several points to pinpoint and later say it could be intestine or it could be lymph nodal mass or it could be something else, right?
Yes, sir.
Go ahead.
1 second, ma'am. Other systemic examination is normal. Summary of the case. 29-year-old gentleman, IT employee from Chennai, married for 1 year, has come with complaints of pain abdomen right or lower quadrant and altered bowel habits whose duration is about 1 to 1.5 months, with a history of anorexia, significant weight loss, no history suggestive of any metastasis, with no contact history of TB, no comorbidities, status post lipoma excision, who is also an occasional smoker. On examination, his general condition is good, with a palpable 6 by 5 centimeters mass in the right iliac fossa extending up to the right lumbar region, which is intra-abdominal with no evidence of metastasis clinically.
Madhura, do you agree her mention about metastasis?
Yeah, I don't agree at all. And another thing which I am not agreeing about, whenever you are putting the summary, now you have to put positive points. Here again, you are stating that no contact history and all that. That is, we have already taken
in
when
history.
you have, yeah, in the history. Here only positive points which can lead you to the diagnosis.
Okay, ma'am.
Swarna, is contact
And
history of
I
tuberculosis, is it
think
mandatory to make a diagnosis of tuberculosis?
It is important, sir, because in India,
Is it mandatory to make a diagnosis of ileocecal tuberculosis that everybody should have a contact history? How do you know
No.
where you are contacted? So don't try to
No.
get into trouble.
Okay, sir. Okay, sir.
now in the common history you can tell that, but in summary now it should be very short and
Okay.
only positive points which we can have benefit for the diagnosis.
Okay, ma'am.
Yeah.
Now, why did you say the ECOG scale here?
Sir, it is, I am suspecting a malignancy. So mostly we will use ECOG score only.
No, but you are always saying your first diagnosis is ileocecal tuberculosis.
Yes, sir. Even, we can say even Karnofsky score, but
No, even the Karnofsky or ECOG, when you are suspecting your first diagnosis is a malignant cause. Okay.
yes, sir. Yes, sir.
In your examination, you said that you examined the pelvis and the scapula.
Yes,
How
sir.
do you examine the pelvis?
Sir, any examination of the pelvis to see any bony deposits are found or any deposits are formed over the iliac crest or any deposits formed near the symphysis pubis for any lymph nodal mass, anything which we could find. And scapula also, because he had a lipoma excision, I wanted to just see the scar, how is it? And
Okay, please do not do it. Na?
yes,
For your next time, these are not examined. Saying examination of the pelvis and they are not done. Na?
okay, sir.
And then you say it's a lump in the lumbar region. Did you say about the ballotment and the bimanual palpation lump?
It's not
The
ballotable.
lump is it is going to the lumbar region.
Yes, sir. Yes, sir. It's not ballotable, sir.
And in the lever span, you said that it is from the fourth intercostal space to that.
Yes.
But the lever span is always in measurements.
Yes, sir.
So is it 11 centimeter or 12 centimeter or 14 centimeters? So you have to tell about the
Measurement.
size
Yes.
measurements of that.
Okay,
Did you
sir.
examine the testes in this patient?
Yes, sir. I did, sir.
Testes was normal.
Yes, sir. Bilateral
Yes.
test is palpable, normal.
He has
So
written,
can you
sir,
have a
some
lump
marks
like
of
this from the testis?
Yes, sir. In case of undescended testis, which is malignant, of a malignant etiology, it can present as a right iliac fossa mass.
Which type of the
Swarna.
undescended testis can have a mass like that? One you said the malignant, but what will the location of that?
It can be at the deep ring location. It will be in the right iliac fossa, sir.
Intra-abdominal. No?
Intra-abdominal. Yes.
Okay. Undescended testis can be in the inguinal region also.
Yes, sir.
But this will be intra-abdominal if it is testis is there, then you can present like that.
Yes.
Okay.
Karna, if this patient would have presented in an acute stage with a lump in the right iliac fossa, one of your diagnosis will be appendicitis or
Yes.
appendicular lump. Any other diagnosis you can suspect?
Ma'am, in acute
Quickly
condition, it
presenting tender lump.
can be a ileocecal TB, ma'am, which is perforating, and there's some perforated any mass perforation of any mass.
Okay.
And
okay, that is one thing. Suppose
yes,
any other thing?
inflammatory bowel disease, which is also having a mass and it's perforated.
Not with GI, other than GI condition?
Acute intermittent porphyria, sickle cell anemia, hematological conditions, ma'am.
No.
The lump is palpable. The lump is palpable.
Yes, ma'am.
There is acute condition.
Lump is there, it is hard.
Lump is hard. Lymph node. Don't know, ma'am.
No?
No, ma'am.
Any abscess? Any abscess?
Psoas abscess, ma'am.
Yeah, any.
Yes.
So
Psoas
you can
abscess.
with acute abscess. Yes.
Yes.
Okay, go ahead.
The pelvis, when you mentioned, I thought whether you are trying to say not swellings on the bone, tenderness.
Lymph nodes.
Tenderness.
Yes,
No,
sir.
no lymph nodes. Don't get into trouble.
Okay,
so if you
sir.
suspect a leukemia, lymphoma, non-Hodgkin's lymphoma, again, as Dr. Madhura has already warned you that it gives an idea of that whether you know the case, you know. So, but if you are asked pelvis, see, we surgeons, we don't examine the pelvis. Don't say pelvis. Rectal examination is different. PV is different. Iliac bone tenderness, bony tenderness.
Okay, sir.
Unless there is a very specific patient points you. Patient says, I have got some pain there, swelling there. Okay.
Yes, sir.
So, that is the time you discuss.
Yes, sir.
In this 29-year-old person with the,
yes,
if the lymphoma is not available for you as the diagnosis, what is your first diagnosis?
First thing is, as I told, ileocecal TB, sir. Second thing will be a probable malignant etiology. It could be a right-sided colonic malignancy.
Why didn't you put tuberculosis here now in the provisional diagnosis?
Yes. In the provisional diagnosis, you should have put the tuberculosis and the malignancy. So this is all again prejudiced.
Never look at the available investigations and never believe in supervisor.
Yes, ma'am.
Even in OPD also, if the patient will come to you, you should not see the investigation first. You have to examine the patient. You should have your diagnosis and then go for the investigation what the patient has brought. Otherwise, it will be a all prejudiced examination.
Yes, ma'am.
Unfortunately, I think nowadays patients come with investigations and throw the investigations on your table. That is the sorry state. But don't
they
fall
will
for
on
that.
their own self.
Yeah, they have their own diagnosis
on
also.
Their own.
Yes, ma'am.
Just one more correction.
No, I think here provisional diagnosis.
Yeah, provisional diagnosis don't say mass arising from right iliac fossa, mass in right iliac fossa.
Okay, ma'am. Okay, ma'am.
And in here you should have told about the I could be query ileocecal tuberculosis and query three things should have been there.
Yes.
So Swarna, I will ask you one question just for the discussion. Any difference is there when you feel a mass? Forget about the age now between the tuberculosis and carcinoma cecum. Any difference is there?
Yes,
Forget
sir.
about the age. Forget about the age.
Yes, sir. Tuberculosis will be having a pulled up cecum, sir, with the rolled over omentum. It will be more nodular and it will be pushed little more.
Don't bring the rolled up
tuberculosis.
Don't bring the rolled up momentum. So don't bring rolled up momentum. Okay, don't get into trouble.
Okay.
Pulled up cecum, all right, accepted. And mobility. See, mobility, pulled up cecum, and most of these patients have a diarrhea. Diarrhea may be a complaint rather than bleeding per rectum. Carcinoma, of course, your patient is good heart, all that thing you have mentioned. So in case if they ask you, get ready with these answers to differentiate tuberculosis and carcinoma based on the clinical grounds, not based on age and all this contact and all that.
What goes in favor of calling it carcinoma?
Ma'am, his
clinically.
age, clinically, ma'am, it's hard in consistency, the mass. And second thing, the mobility is very restricted vertically and more on the transverse direction. And it is dull on percussion and there's nodularity.
Okay. And rapid weight loss.
Rapid weight loss. History-wise, age, rapid weight loss, and the history is also a short duration history.
No, why are you saying age?
Age?
25 years. You expect someone to have a malignancy.
29.
All the time, from the first slide, we have been telling you 29 years, and you have been again repeating the same mistakes. Don't do it. Don't do that.
Sir. Yes, sir. Yes, sir.
Look, in this, Suvarna, I just want to tell you something.
Yes,
in this case, clinically, in spite of everything, I will not suspect malignancy as my first.
Yes, sir.
Right?
Yes, sir.
Anything other than malignancy will come to my mind. I had a 25-year with a 1.5 month history. With, I mean, weight loss is very objective. It is not a subjective thing. You don't have, it is, I mean, it is not quantified here, isn't it? We don't have the weights.
Yes, sir.
So with no free fluid, with no lymph nodes, with nothing other palpable in the abdomen, why should I think of malignancy?
Yes,
right?
sir. Yes, sir.
You've got so many points against malignancy than for malignancy. So
Yes,
please
sir.
refrain from that.
Yes, sir.
Moral of the story is that not only age, tuberculosis also can give rise to heart. Tuberculosis also can give rise to restricted mobility. Tuberculosis also can give rise to all the possible things. You know, they are great mimickers. So what is common in 29-year-old, you should try to think as first diagnosis, right? Yes.
Yes, sir.
And do you have any other diagnosis now? If the examiner asks,
tuberculosis or probable malignancy?
no, that is as per the ileocecal area which we have discussed. What are the common any other 2-3 masses from the intestines you can think of if the examiner asks you?
From the intestine.
Intestine, when I say intestine, colon, whatever. Can you think of anything else?
I can think of intussusception.
Intersusception. Do you think it's possible here?
No, and it is more common in a younger age group than an older age group.
Not younger age is not, that is not the point. Point is the consistency you mentioned, the concavity, the emptiness, all that.
Duration.
Duration.
Yes.
Anything else? Any other masses? So this is the time where you need to answer something now other than these two. If the question is asked, stromal tumors you heard of?
Yes.
What is that? What is that?
Gastrostomal tumor, which is a extraluminal pathology of the intestine.
Now I will ask you at all the time talking about appendicular pathology. Now you
abscess.
Tell me.
Appendicular abscess. No, mass, appendicular mass, lump.
Is it a tender or non-tender mass?
Appendicular, sir. It will.
Your case, tender or non-tender?
Non-tender.
So you are telling appendicular abscess. What is this? So what I wanted is large mucosa. It's not that, you know, anything is possible, appendicular, neoplasm, etc. But don't tell it as a first. If let the exam, if you are asked intestinal pathologies which can present as a mass, last you should come out with just lymphoma and all that thing. But I think we should be extremely careful. Better not mention.
Any retroperitoneal mass?
Retroperitoneal.
You will suspect or you will not suspect?
We will suspect, ma'am. We will suspect
and
it.
If it is there, anything else to be, we have to see?
We have to see. We have to see if it is a mobile mass or is it fixed for retroperitoneal or is it palpable on only deep palpation it will be palpable.
And what effects it will having? It may be having if the retroperitoneal mass is there.
There'll be this one, ma'am. What do you call? There'll be a abdominal distension, large retroperitoneal mass, and then it can be having IVC obstruction.
Yes.
Visible veins, ascites.
Yeah, and there may be palpable kidney, hydronephrosis and all that. So maybe possibility.
Or even an ectopic kidney might be palpable.
Yeah.
So, Swarna, adding on to whatever Madam just now told you, compression on the vein, one of the earliest indication in a retroperitoneal tumor is unilateral lymphedema. So always remember, whenever a patient comes with a unilateral lymphedema, always you should be more alert. And second is If this mass is compressing on the artery, you should have told transmitted palpations.
Yes, sir.
These are some of the very key points for you to help in the diagnosis. Sir, it could be retroperitoneal. This is how you analyze. Okay, please go ahead.
Next. Okay, you have told us your provisional diagnosis. What are you planning to do now?
Ma'am, first thing, I would like to investigate the patient. First thing for the general condition of the patient. Second one is to know the diagnosis of the patient, which previously I had mentioned, but for knowing the general condition of the
forget
patient.
the investigations that have been done. Tell us what you will do.
Yeah.
We will first do, for general condition of the patient, we will be doing a complete blood count.
No, I don't need to leave those, Mama. I don't need to leave those, Mama.
Hello.
Mic is on from kitchen.
Yeah.
It's okay. Tell us the investigation, specific ones.
Specific, ma'am. Ma'am, I would like to do a complete blood count to rule out anemia or any infective pathology, rise total counts and ESR and everything. And then I would like to do an LFT to know if there's any jaundice or how is the liver function. I would like to do the kidney, the renal function tests such as serum creatinine, blood urea and all to rule out if there's any renal parameter delineament. And then I would like to do CEA for this patient because I'm suspecting a malignancy. And
Has
then
CEA been done?
Yes, ma'am.
So what is the report?
It is 1.46, ma'am. It's normal.
Okay.
And then I'd like to do an ultrasound abdomen first to see for an extension of my examination to know the organ of origin. Is there any free fluid present? Is there any lymph node or are there any liver mets to do to rule out all that? I would like to do an ultrasound abdomen, and then I would like to do an colonoscopy and colonoscopic biopsy to see if there is any mass, if there is any polyp, if there is any synchronous lesion, or how is the mass, what is its extension, and I wanted a histopathological confirmation of my diagnosis.
And what else? What else will you look for on colonoscopy?
I will look for synchronous lesions, ma'am.
That's important, no?
Yes, ma'am. Any polyp, any synchronous lesion, biopsy from the mass, how much, what is the extension of the mass? It will help for my further plan.
You will prefer CECT or you will prefer colonoscopy?
Ma'am, if I want to get a confirmed histopathological diagnosis of my case, I would prefer a colonoscopy guided biopsy.
But still you have to go for CT scan. Why?
I would like to do CT scan to know the status of the lymph nodes, to know to have a better delineation of the mass and the surrounding structures, to know how much, if any ureter or anything is involved. All that I would like to know, all the detailing I would like to know, do a CCT.
And metastasis.
Metastasis. Yes, liver metastasis. But liver metastasis can be made out in ultrasound, ma'am.
Yes, but details and visualization will be proper. If you do CT scan, you yourself also can see whether the metastasis is there and all that.
Yes, ma'am. Okay.
Then now let us not ask you what is the diagnosis on colonoscopy. Let's presume that it is adenocarcinoma.
Okay, ma'am.
So
adenocarcinoma.
Madam, we can. But for this case, first we'll discuss. You said that this is a lymphoma.
Okay.
Yes.
Go ahead.
How will you plan for this patient?
Ma'am, lymphoma. We will plan for an immunohistochemistry, ma'am.
Okay. Why?
We would like to do CD markers to confirm what is the proliferation, what kind of lymphoma it is. And then we have to plan. If it is a lymphoma, the plan will be chemoradiation.
Okay.
Because surgical indication will be if it is an unresponsive to chemotherapy, or if there is an perforation, or if it is an obstructive lesion. All those are surgical indications to do a surgery, to plan for surgery.
Okay.
Sir, excuse me, ma'am. Can I interrupt? Swarna, can I
Do you want to go diagnostic laparoscopy?
Ma'am, diagnostic laparoscopy will not have much of value because already we have a colonoscopic biopsy and a CECT. If you are planning, then diagnostic laparoscopy will. If you are planning
for lymphoma involving bowel, do you use radiation?
No, ma'am. Chemotherapy is the first line.
Yeah. Why don't you use radiation?
Ma'am, there will be the bowel. There will be a lot of strictures. Post-radiation effects will be more.
Yeah, I mean, you simply can't give radiation to bowel.
Yes, ma'am. Yes, ma'am.
Karnakaran sir, you wanted to add something, sir?
Yes, sir.
Yes, sir.
If you permit. Swarna.
Yes, sir.
Am I audible?
Yes, sir.
In that case, we can talk hypothetically if it is a case of lymphoma.
Yes, sir.
Confirmed with IHC.
Yes,
Okay.
sir.
Yes or no?
Yes, sir.
One single important investigation which is mandatory in case of lymphoma.
Single investigation.
It is a must for the management of lymphoma. See, already you have confirmed the diagnosis with IHC. Yes?
Yes. Yes, sir.
You may say whether it is Hodgkin's or non-Hodgkin's.
Yes, sir.
Okay. I am asking one single important investigation which can decide the treatment. Can you guess or can you try?
No, sir.
Okay,
What is the staging of the disease here?
So, ma'am, it is stage staging only a single group. Stage 1, ma'am.
How come? Just tell me what are how the staging is done in lymphoma.
Stage 1 is one group of lymph nodes involved. Stage 2 is multiple group of lymph nodes involved on the same side of diaphragm. Stage 3. Stage 3 is bilateral involvement. Stage 4 is extranodal sites. Stage X is bulk more than 10 centimeters of size. Stage E is isolated extranodal.
So you think that this is stage 1, but the lymph nodes here are how many lymph nodes on CT scan?
CT many pericolic lymph nodes only were told, ma'am. Number was not told.
Okay, only pericolic lymph nodes are there.
Yes,
that's why you think that this is stage 1.
Yes, ma'am.
Okay, what chemotherapy agents we can use for this patient?
Ma'am, we can use a R-CHOP regimen, ma'am. Or
Okay,
we can R-CHOP is rituximab, cyclophosphamide, oncovin, doxorubicin, and prednisolone, ma'am.
Okay, COPP?
COPP is prednisolone, procarbazine, vinblastine, and cyclophosphamide.
Okay. So
And
this
what
you
type
will
of the
prefer.
lymphoma it is?
It is based on the immunohistochemistry markers, sir.
No. Is it a primary GI lymphoma or it is a secondary GI lymphoma? And what is the difference between these two?
Secondary GI lymphoma will have any other node positivity. This should be a primary GI lymphoma.
So how do you define that? What are the criteria to say it is a primary GI lymphoma?
No, no, sir.
The disease is confined to the GI tract only. There are as such no lymph nodes anywhere else in the body. There is no leukocytosis.
Yes,
The
sir.
bone marrow is normal. Then you can say it is a primary GI lymphoma.
Yes, sir.
But otherwise, it is a part of the secondary lymphoma. Okay, so
Okay, sir.
lymphoma is somewhere else and GIT has been involved accidentally, or it is a stage 4 disease because of that. You know?
Yes, sir.
Probably if you are dealing with a case of lymphoma here, you are dealing with a case of a primary GI lymphoma.
Yes, sir.
Tell what are the indications of surgery in the primary GI lymphoma?
Sir, if it is obstruction, perforated, or if there is, I mean, if it is unresponsive to the chemotherapeutic agents.
No, like your
And
patient
if
is
it is,
neither bleeding.
yes,
Okay,
sir.
your patient is neither bleeding. There is no evidence of any perforation is
Obstruction.
there. There is no evidence any obstruction is there.
Yes,
So would
sir.
you like to operate this patient or not? Just presenting like a lump in the abdomen.
No, sir.
I think for this patient, laparoscopy, diagnostic laparoscopy is indicated because we want to know whether the peritoneal mates are there or for taking biopsies and all that.
Okay,
What
ma'am.
is your opinion, Khanna sir? Your mic is off, Khanna sir.
That doesn't really change our treatment plan because he is not obstructed. So he goes on chemo anyway once we have the diagnosis and the type of lymphoma with us. So doing laparoscopy doesn't really change the treatment plan.
Okay.
Can I?
Yeah.
Swarna,
Yes,
so the
sir.
single most important investigation is PET scan. Without
Okay,
a PET
sir.
scan, you cannot do anything in
Yes.
lymphoma.
Okay.
Okay.
Yes.
Apart
Okay, sir.
from that, if it is a case of Hodgkin's lymphoma, what is your ideal chemotherapeutic regimen?
ABVD regimen, sir.
Why ABVD? Why it is ideal? What is the advantage of ABVD over other regimens?
I don't know, sir.
So there is a two significant advantage. What are the other regimens you know?
ABVD regimen, then
Leave alone the ABVD regimen. You go to some
then
other things.
paclitaxel.
See, previously we used COP.
Yes, sir.
COP, am I right or wrong?
Yes, sir. Yes, a MOP regimen.
Non-proven prednisolone procarbazole.
CVP regimen.
The distinct advantage of ABVD is it does not produce any leukemogenic effect. When you give a chemotherapy for a lymphoma, after a decade or later, the patient may develop a leukemia because of this drug. These drugs produce leukemia. The minimal or nil leukemogenic effect in ABVD regimen, number one. Number two, it does not produce infertility, otherwise sterility. Whereas the other chemotherapeutic regimens produce infertility or sterility. So ABVD has almost replaced other regimens in case of Hodgkin's lymphoma. Yes?
Yes, sir. Yes,
So,
sir.
In this case,
Swarna, just want to add on to what sir told you just now.
Yes, sir.
Whenever you have young patients, especially
Yes,
when whether it's whatever be the disease, lymphoma especially, pelvic radiation or chemo is when there's a doubtful suppression and toxicity, sperm preservation, you should always keep it in mind. Is
Yes,
it clear to you? Okay.
Yes, sir.
Right.
Yes,
That's
sir.
important.
Yes, sir.
okay, what will be your plan if the patient, this patient is diagnosed as adenocarcinoma of the ascending colon?
Ma'am, adenocarcinoma of the ascending colon, I would first plan a right hemicolectomy after a confirmed
This is
biopsy.
a large size mass.
So I'll give a neoadjuvant chemotherapy for after 3 cycles. After assessing the response, I would like to do a right hemicolectomy, ma'am.
What made you to decide chemotherapy?
It's a large mass.
Is there a size criteria for especially right iliac fossa? Is it operable? You need to have mentioned. You would have
operable based on the operability.
CT scan.
Operable and no metastasis.
I can.
Important things, no. So as long as the CECT criteria, you should know the route of the mesentery, major vessels are the contraindication. Colonic cancers, even if ureter is infiltrated, you can always, either sacrifice even a small segment of the ureter, not consider it as inoperability, etc. Colonic cancers have got a good unless there is a peritoneal metastasis, liver metastasis, etc., etc. So
yes,
I may be Kanakavellu may be able to tell it better. Dr. Kanakavellu, as far as the large colonic tumors, whether initially you start with upfront chemo in the absence of metastasis.
Sir, the current guideline for the neoadjuvant chemotherapy essentially is to improve the resectability rate in a advanced tumor. Either it can be locally advanced or a metastatic tumor, sir. Number one. If a surgeon can do in fact, madam was asking about the staging laparoscopy at that point of time.
Correct.
So we always, if the patient has features of complications, obstruction, perforation, or bleeding, then the priority is for cleaning resection. If the patient does not give features of complication, patient to improve or to give a R0 resection, then the neoadjuvant chemo or chemo bar radiation comes in. If there is an invasion to the adjacent structure, especially if the patient is having ureteric involvement or if the patient is having vascular involvement, then maybe we may consider downstaging. But by and large, sir, unlike rectal carcinomas, now only very minimal or publications are coming up for the colonic cancer as a neoadjuvant concept is coming in, sir. The point is to improve the R0 resection at this point of time is the only condition neoadjuvant therapies are being tried upon. Rest of the thing comes under the all other things comes under the category of experimental stages only, where locally advanced infiltrating type or metastatic type of cancers are given a neoadjuvant therapy, provided the patient does not have complications, sir, which is fairly unlikely, sir, because when the tumor is advanced, they invariably come with some coexisting troubles. So very difficult to decide upon neoadjuvant therapies in colonic tumors, unlike in rectal tumors, sir. But for exam's sake, improve the R0 resection, improve the resectability rate of the tumor. Even R1 resection is acceptable, provided you are going to preserve the structures. Number 4, when the patient is not in any form of complication, you consider neoadjuvant therapy. That remains the clauses, sir. Maybe Kanna sir and others can add up to the points if I missed out on something, sir.
Okay. And if this would have been tuberculosis, what your plan?
Hello.
No, madam wants to know, Swarna, if it is biopsy has come as tuberculosis, what will be your approach? Right, madam? Go ahead, ma'am.
Yeah, it is a non-obstructive lesion, ma'am. I would like to start him on anti-tubercular regimen.
What is that?
That is rifampicin, isoniazid, ethambutol, pyrazinamide. 6 months.
No.
All for 6 months?
No, ma'am. For rifampicin, isoniazid, and ethambutol. Rifampicin, isoniazid, ethambutol, and pyrazidamide for 2 months continuously, thrice a week, plus 4 months of rifampicin and isoniazid.
Small corrections for now. 4 drugs for 2 months and 3 drugs for 4 months.
Ethambutol. Yes.
How do you give these 4 drugs? What is the dosage of that?
Sir, rifampicin is 10 mg per kg, sir. Isoniazid is 15 mg per kg. Ethambutol is 30 mg per kg, and pyrazinamide is 35 mg per kg.
No, I think the simple I will tell you.
450
5, 10, 15, 20.
Okay.
5 milligram is INH, 10 milligram is rifampicin, 15 milligram is ethambutol, and 20 milligram is the pyrazinamide. Okay.
Yes,
so
sir.
just remember
Yes.
5, 10, 15, 20.
20.
So what type of the intestinal tuberculosis it is? You know what are the various types of intestinal tuberculosis?
Yes, sir. Ulcerative, hyperplastic, and mixed, sir.
So which one is the primary intestinal tuberculosis and which is the secondary intestinal tuberculosis?
Hyperplastic is primary intestinal tuberculosis, sir.
Why do you say it is the primary?
Sir, it is because of contamination, ingestion of direct injection of any tubercular sputum, or it is because of there's no any chest pulmonary, any pulmonary tuberculosis history will not be there, and it is less virulent.
Sputum will not come in the primary, isn't it?
It won't.
Yes, sputum will be in the secondary variety.
Secondary variety only sputum will be there.
So where the host resistance is poor, virulence of the bacteria is high, and it is secondary to the lung tuberculosis. So that is the ulcerative variety.
Ulcerative type.
Okay.
The patient may need surgery even after giving anti-tuberculosis treatment. Why?
Ma'am, if his responsiveness is poor, if there is any obstructive features, stricture formation.
No, he has responded well, but the healing is always by stricture formation.
Yes, ma'am. Stricture formation.
So he may still develop obstruction.
Yes, ma'am.
And then need surgery.
Yes, ma'am.
So what is the option for a stricture? What can you do?
If it is a single stricture, we can go ahead and do a stricturoplasty, sir. If it is multiple stricture with long segments, we can do multiple stricturoplasty. If it is a short segment, the multiple strictures will do resection anastomosis.
You know who gave the concept of the stricturoplasty?
No, sir.
Any idea who gave the concept? It's an Indian surgeon who gave the concept of the stricturoplasty in tuberculosis.
Don't know, sir.
It's Dr. Kataria. No, he's from Chandigarh, PGI Chandigarh. He gave that concept. So it's the same like the Henneck-Macaulay concept which is there, which we used for the stomach. So a similar concept which is there for the, and now it has been also taken even for the Crohn's disease also, where the long stricture is there. In tuberculosis, you get a very short stricture.
Yes, sir.
But in Crohn's, there are a long stricture. Even in those cases also, you can go for the stricturoplasty.
Yes.
Should we,
I think we should close this case.
Should we close at this point?
Yes, madam. Swarna, do you have any doubts to clarify?
No, sir.
Thank you. Kanna sir, you would like to give closing comments, sir? Anything else?
I just wanted to tell Swarna that, you know, whenever you get a patient, especially of the malignancy, your order of investigation is not the general investigations and then for the diagnosis. Okay, your order of investigation is, first is always to make a diagnosis.
Yeah.
Yes.
Second is to rule out any
Other causes.
metastasis there. Okay, so metastatic workup. And the third is the general investigations to be carried out for the treatment of that particular patient. So that should be order of your investigation.
Yes.
And don't try it in the exam, all investigations, even if you know this case and all that.
Yes.
Okay.
Yes,
Okay,
sir.
good.
Thank you, ma'am.
Thank you, everyone.
Thank you,
Thank
ma'am.
you.
Thank you, sirs,
Kanna.
everybody.
Thank you.
Madhura ma'am.
Bye.
Thank you, Madhuri ma'am. Thank you, Samita ma'am. And thank you all the senior
Thank you.
Our
faculty.
pleasure.
Thank you everyone.
Thank you, Dr.
For
Khanna.
doing the setup.
Thank you, Kanna
Thank you,
sir.
Dr. Madhuri. Thank you very much.
Thank you, Karnakaran
Thank you.
sir, Chandru, and
Thank you,
all
sir.
the
Thank
senior
you to all.
faculty.
Thank you, Karna sir.
Rajiv Sakai.
Thank you, sir.
Bye, Madhura.
Bye-bye.
Okay. Bye. Sir.
Good night, everyone.
Good
Good
night.
night. Good night.